Hi, Dr. Bila. We are ready to go.
Okay, thank you, Kamo. Thanks, colleagues, and thanks for coming in large numbers once more to join us for this weekly webinar hosted by Clinics Health Group. It's been a long journey, and we are glad that you've all stuck with us in this journey of continued medical education, and that you've allowed us to be with you and to share this information that we getting from different experts from different fields in the healthcare industry, both in the academic sector, from the clinical fields and researchers, and from different disciplines, medical, allied health disciplines. We even had dentists. We should be having one again this year, and from nursing fraternity. And as usual, around May, we celebrate Nurses Day. We should be doing that again once more this year. And we kickstarted this webinars with our own professors who are helping us within the Clinics Health Group fraternity. And we are glad that they've availed their time to be with us and share their thoughts and experiences, both in the public and the private sector, as they've gained a lot of knowledge and experience in training and helping doctors, registrars, and even overseeing consultants to mature and develop into experts in their own fields, in the various fields that they have been working in. And so tonight also we have the same, it's a continuation of the third week now that we've got one of our experts who's working with us within the Clinics Health Group, but they are still attached to their various universities and hospitals. And these webinars are CPD accredited, as we have always been saying. And so when you join in, you get your CPD points. And also note that these webinars are also streamed live on YouTube. So at any time when you want to go back and watch and listen to the various presentations, you are at liberty to do so, to listen to them. We know that tonight we have a challenge. The president of the country is giving a State of the Nation address, but we'll keep it tight and make sure that you don't miss out on the developments in the country. But tonight we have a renowned professional, a speaker of note, and also clinician, Professor Jeff Wing, who is speaking to us on diabetes emergencies. And we've given you a short CV that Professor Wing is a physician and also an endocrinologist with a special interest in diabetes. He's given us a brief resume. I think it's a bio. There's a lot that you can write about Professor Jeff Wing. He's a project leader, formerly with the Vets Health Consortium, for the equivalent equity investment program since 2021. And the aim of this unit is to establish a cardiometabolic renal medicine within an integrated service and training platform. He collaborates with other universities like the University of the Witwatersrand, University of Pretoria to date, and stakeholders in the provincial, local, and health departments, many NGOs, private companies, to implement the program. And Professor Wing has been a member of the University of Johannesburg Faculty Committee since 2020, as we might be aware that there's a new faculty being established at UJ. And his role there is to contribute to the new curriculum for and medical students. Is also responsible for establishing a new clinical academic health program for UJ. I've had a conversation with him about what this means and what it means for Clinics Health Group, and I think in due course we'll be making an announcement. He has authored and co-authored 65 peer-reviewed publications and is a principal investigator in clinical trials, completed about 66 to date in the fields of diabetes and metabolic disease. So we're glad that Professor Wing has agreed to speak to us on the subject of diabetes emergencies. Prof. Wing, thank you very much, Jeff, for being with us this evening.
Thank you, Ray, for those kind words. And it's a pleasure that I'm honored that you invited me. As you mentioned, there's a bigger program happening at 7 in Cape Town. So we're going to try to finish on time. So I think what I will do, if people don't mind, I'll switch the video off. So it gives us more bandwidth, and perhaps the presentation will be also clearer. Right, so I was asked to talk about diabetes emergencies and particularly focus on hyperglycemic emergencies. So as you can see, the spectrum here is diabetic ketoacidosis, the hyperglycemic hyperosmolar state, and thirdly, a hybrid of these two conditions. So what I want to do today is not go through everything in great detail, because this is easily accessible in many reviews and guideline documents, but rather to offer a focus on how we can refine acute care. So let me try and define what I'm trying to say. So I look for a starting line. Most Western lecturers would say, start with a joke. I decided not to. Most Asian Eastern lecturers would usually start with an apology. And I don't want to do that. So I thought I'd look up an African proverb because I often find them simple, but yet very insightful and full of wisdom. So I found this one. Unfortunately, I don't know who the author is, but it says this: we should not look where we fall, but rather look where we started slipping. So being involved in the many M&M meetings with the clinics group, I think by the time we've fallen, we often bring up an M&M and often a post-mortem report as well. So I would imagine the president in his speech tonight is going to have the same sort of sentiments, and hopefully the falling will stop and we'd look at the slipping and try and find solutions there. So in the setting of diabetic ketoacidosis, what are the slips that we make? And if we fall, then the patient has a very severe outcome, i.e. death, which is in the range of about 4 or 5% in the setting of acute DKA or hyperosmolar coma. So what I want to do is spend about 5 to 7 minutes looking at the pathophysiology, not so much to irritate you with second-year biochemistry and biochemical pathways, but rather to show you and summarize what happens in the setting of DKA and HHS, and emphasizing how this integrated catabolic cascade leads to the coma, and then spend lots of time on the clinical management. But I'm going to base the clinical management on what this catabolic cascade tells us about, and likewise look at how we integrate treatment in trying to reverse this. Okay, so just a few slides. I'm sure you all know this. So the starting point of this is too little insulin and too much of the counter-regulatory hormones, glucagon, cortisol, catecholamines, growth hormone. Result is dehydration and ketoacidosis. The cascade of this imbalance, hormonal imbalance, is usually precipitated by stress, infection, and or insufficient insulin, which in many cases is related to compliance, poor compliance. So what we know is the excess of counter-regulatory hormones is influenced by an absolute deficiency of insulin in the case of DKA, and hyperosmolar coma, a relative deficiency. Now, this is important because the dose response of insulin inducing ketogenesis and the dose response of insulin maximizing glucose uptake and suppressing glucose production is very different, and hence the different manifestation of these two hypoglycemic conditions. So where there is absolute insulin deficiency, there is not enough insulin to suppress glycogenolysis, gluconeogenesis, and also maximize glucose utilization, and hence hypoglycemia supervenes. Likewise, with severe insulin deficiency, there's unregulated lipolysis, and hence ketoacidosis and hyperlipidemia. Where the insulin deficiency is relative, ketoacidosis, hyperlipidemia is less common, or if it does happen, it's in fact much milder. And the emphasis here then would be on the hyperglycemia, the osmotic dehydration in terms of renal loss, and the hyperosmolar state. So organs at play: too little insulin, too much counter-regulatory hormones. Muscle is a source of glucose, glycogenolysis. It's a source of amino acids in terms of gluconeogenesis. You can see at the bottom, in the serum, contributes to hyperglycemia. Liver is central, again, a source of glucose in terms of glycogenolysis. It's the major source of gluconeogenesis in terms of these amino acid substrates. And importantly, it's the major source of ketogenesis. Ketogenesis arises when insulin can't suppress lipolysis, and there's unbridled free fatty acid delivery to the liver. Last but not least is the issue of adipose tissue releasing prostaglandins. These contribute to nausea, vomiting, and in turn, the compensatory mechanism of fluid intake is lost and the dehydration is worsened. Right, here's gluconeogenesis. I'm not going to go into all of this, but this happens in the liver. Here is lipolysis, shown on the right in blue, the blue arrows, and where ketones and how ketone bodies are formed. The major one is hydroxybutyrate, so this we must remember, and acetoacetate is the major one that we find in the urine in terms of a ketone dipstick, but it's the minor fractions. So often we tend to measure this one because of ease, but it's the least important of the ketone bodies. Also in terms of deciding when or not to stop treatment. Okay. One may say that this sort of decompensated state reflects starvation, in that in the absence of insulin, the body switches to a catabolic cycle, and the use of glucose is not possible because there's no intracellular mechanism to deliver this glucose. And so ketones are the major substrate for energy production. When there is shock and dehydration, there's inadequate tissue perfusion, tissues go to a fermentative state in the absence of oxygen, i.e. perfusion, and the Krebs cycle in the mitochondria doesn't operate, and hence the lactic acidosis. Last but not least, back to the liver, where there's lots of lactate, the liver would in turn convert some of this lactate back to glucose and worsen the hypoglycemia, the so-called Cori acid cycle. Okay, so let me go to the clinical framework now. So to diagnose DKA, these are new criteria ADA, EASD, and various other regulatory agencies have put out. And as you can see, in terms of DKA, the criteria to diagnose this is a pH less than 7.3, serum bicarb less than 18 millimolar, hydroxybutyrate in the serum greater than 3, and ketone bodies in the urine +2. In terms of the criteria for hyperglycemia, this is a glucose of 11.1 or more, and or euglycemia. So I'm going to mention this later on, the concept of euglycemic ketoacidosis. So in this setting, the glucose is not that important where the patient is being treated with an SGLT2 inhibitor. In terms of HHS, the typical criteria is a glucose over 33.3 and a serum osmolality greater than 300. So I mentioned too that a third version of these hypoglycemic emergencies is a hybrid of DKA and HHS. And this is happening quite often and largely related to the changing dynamic of what diabetes is. It's known with the watertight of a young type 1 and an older type 2, but there's now delayed type 1, there's type 2 in young people, in fact, in adolescents. So one just needs to remember that often these watertight siloed criteria, DKA and HHS, don't apply clinically, and we must be aware of the overlap and the hybrid version of this emergency. Okay, so going back to the clinical issues, I like to look at a mortality staircase. So remember, this is where the slipping happens. And in terms of ranking, I like to look at it in terms of the following. So dehydration, hypovolemia is the first slip. So that requires the most attention. The second slip in terms of leading to a fall, i.e. mortality, is the acidosis. The third one is that of electrolyte abnormalities. We often forget about precipitating factors and complicating factors. So often there's an underlying infection that is causing the decompensation. Often there's also a diabetes-related complication. The patient gets a stroke, has a myocardial infarct, and then presents with hyperosmolar coma. So we mustn't forget those too, because they need treatment. And last, as I mentioned, is the glucose. So in a little more detail, the dehydration hypovolemia is hypertonic in nature. And obviously, to avoid this slip, one needs to reverse the shock, the hypovolemia. But over the course of treating the abnormality, the hypoglycemic abnormality, we must remember that because it's a hypertonic type of dehydration, we need to replace free water as well. Acidosis, life-threatening acidosis, as mentioned, is defined when the pH is less than 7. The need for bicarb here is needed, and I'll go through this a little later. The major cause of acidosis is that of ketosis, as I mentioned earlier, in those biochemical pathways. There is lactic acidosis, and is the renal contribution to the bicarb deficit. In terms of abnormal renal perfusion, the GFR decreases in the presence of dehydration, and bicarb generation is absent. The fourth type of acidosis is that of hypocalemic, hyperchloremic acidosis. And this one is often iatrogenic in origin and very, very difficult to reverse. So I'll mention a little about this later on. The major issue of electrolytes is that of pseudohyponatremia and obviously hypokalemia. As I mentioned, precipitating complicating factors, sepsis, acute kidney injury, stroke, and other complications mustn't be forgotten. And in terms of the glucose, it may be high, it may be normal, and in the setting of what we're dealing with, it's often incidental, and hypoglycemia can supervene, but again, this is often iatrogenic. Okay, so let's go through the dehydration in a little more detail. So current recommendations is the use of crystalloid fluids, not colloid, to restore hypovolemia shock. Administer crystalloids 20 mils per kilo per hour. That is usually a liter to a liter and a half in the first hour. As the hypovolemia is reversed, maintenance fluid in the order of 4 to 14 mils per kilo per hour is needed for the duration of therapy reversing the ketoacidosis. When the glucose drops below 13 millimoles, then dextrose water is needed, because remember, to reverse ketosis, one needs insulin and glucose. A useful formula in anticipating how much free water would be needed, this is after resuscitation with crystalloid is given, because you would recall that just by rehydrating this patient, one can reduce the serum glucose to 15, i.e. to the renal threshold level. This is in the absence of any insulin. So the refined way of looking at fluid management is to restore the intravascular compartment with crystalloid, to maintain this at a lower rate, as I mentioned, 4 to 14 mils per kilo per hour, and to replace free water, i.e. with 5% dextrose water, because this would be needed anyway to reverse ketosis. So the volume of free water that may be needed over the remaining 24-hour period can be worked out by this useful formula, 0.6 body weight times 1 minus 140 divided by the corrected sodium. So remember, the sodium has to be corrected, because the measured sodium in the presence of high glucose may be inaccurate. So a further refinement here in terms of fluid, there's been a huge debate about whether the use of normal saline or Ringer's lactate is preferable. If you read the endocrine literature, it tends to favor normal saline. If you follow the ICU literature, there's a stronger leaning to Ringer's lactate. So just for everyone's comfort, I'm only aware of 1 or 2 small studies looking at the fluid regimens, and both of them were inconclusive. So it probably doesn't matter which fluid you give. provided what's more important is to focus on reversing the dehydration and restoring intravascular volume. However, if you want to be fussy and you want to be a little more elegant about it, the pros and cons of saline and ringers are listed here. So normal saline is normal saline. It's got sodium chloride. Ringers has got sodium chloride, potassium chloride, calcium chloride, and lactate. So in theory, there's a lower sodium and chloride load in terms of fluid management, and some people feel it's beneficial. pH, again, is more in favor of Ringer's lactate. So is the osmolality, 286 versus 273. One downside of Ringer's is the fact that there's lactate there, and some people feel that you induce that Cori cycle and you aggravate the hypoglycemia. But most of us feel that's more of a theoretic issue. There's one or two surgical papers that suggest that Ringer's lactate versus normal saline seemingly has an anti-inflammatory effect. No one knows the mechanism, but CRP seem to be lower with the use of Ringer's lactate versus normal saline. So on balance, probably no difference in what you use, but probably Ringer's would offer more refinement. Right, so that's the hydration bit of the management. What of the acidosis? So consensus is if the pH is less than 7, bicarb must be given. So the bicarb deficit must be corrected, but only at the quarter level. So one would work out the total bicarb deficit based on that formula there, and only divide that amount by 4 and only offer quarter correction. So reason being is if full correction of the bicarb deficit is offered too quickly, we get all these issues arising. Cerebral edema, particularly in children, paradoxical CNS acidosis. If you remember the CO2, HO2, carbonic anhydrase flux, you can work this one out, because remember, CO2 diffuses freely into the brain, whereas bicarb doesn't. So paradoxically, if you overcorrect the bicarb deficit too quickly, you may induce more CNS acidosis. So the serum gets better, but the CFS gets worse. You all remember the oxygen dissociation curve, where acidosis shifts the curve to the right, and this is a compensatory mechanism to limit the effect of hypoxia and reduce tissue perfusion. And the argument is if we correct the bicarb deficit too quickly, we move this curve back to the left, and we induce more ischemia and hypoxia at the tissue level. And probably the most important aspect of why quarter correction is necessary is the intracellular shift of potassium and hydrogen occurs, and a rapid correction of serum pH will induce hypokalemia and obviously cardiac arrhythmias. So where the pH is more than 7, one doesn't need to give bicarb. And here, the only way to reduce ketosis is the use of insulin. So usually, the recommendation is if the potassium allows, so in other words, there's no overt hypokalemia, intravenous insulin 10 units hourly should be given. And as a safety mechanism, as a refining option 2, is to give one single dose of long-acting insulin subcut. This covers issues where there may be delayed insulin administration, where the drips run tissue, and one doesn't want the patient not to have depot insulin, because then relapse of ketosis happens very soon. So refining aspect is for casualty when they diagnose DKA to at least give one dose of long-acting insulin. So remember, to reverse ketosis, one needs insulin and one needs glucose. So when the glucose reaches to the 15 millimolar mark, one would add in 5% dextrose to the fluid regimen. So the treatment hence is 5% dextrose water and hourly insulin until the ketosis is reversed. Lactic acidosis is easy, just rehydrate the patient. Bicarb generation is equally easily reverse dehydration and restore renal GFR. So here's the one that's a little bit more difficult. So hypokalemia, hyperchloremia. So there's only been 1 or 2 studies looking at why this tends to happen. And it would seem that where the dehydration is not too severe, and the clinicians, however, offer too aggressive fluid replacement, particularly if they're using normal saline, then one tends to get a washout of ketone bodies. But remember, ketone bodies are washed out in the kidney as ketone salts. So this would be sodium ketone body, potassium ketone body, and one tends to wash out lots of potassium, some sodium, but not the chloride. So over vigorous replacement of fluids when it's not needed can contribute to this. One other refinement to trying to avoid this is when correcting the potassium deficit, which we know we are going to have to do, total body potassium in the setting of these emergencies is low and needs replacement, is the use of K-phosphate rather than KCl, again limiting the hyperchloremia. Okay, so the electrolytes, the first one is that of sodium abnormalities. And the big issue here is to be aware of pseudo-hyponatremia and not treat it. So remember also, when we try to work out the free water deficit, we need to correct for the measured sodium. And here's the formula for the corrected sodium. So it's the measured sodium, glucose in milligrams per deciliter. It's an American formula, so you'd have to convert the glucose to milligrams per deciliter minus 100 and times that correction factor. So for instance, where the glucose is about 30 and the sodium is 120, using this formula, one would find that you'd have to add 9 or 10 millimoles to the measured sodium, and that would bring it from 120 to the 130 level. So that gives you a true indication of the corrected sodium. So important here is not to treat pseudo-hyponatremia. I mentioned the issue of avoiding hyperchloremia to avoid that hyperchloremic acidosis. Right, so we know potassium, total body potassium will be deficient, and we're going to have to replace it. Most guidelines would suggest measure potassium hourly to 4 hourly and replace aggressively. Remember, back to basics, don't give insulin if the potassium is low, worsening the hypokalemia and arrhythmias. In the setting of casualty, ECG is often useful not only to exclude myocardial problems, but to look at U waves. K-phosphate, as I mentioned, may be a refining option rather than KCl. remember, in this setting, there's often hypophosphatemia as well. So one, in a sense, would be killing two birds with one stone, avoiding hyperchloremia and reversing hypophosphatemia. Okay, so most guidelines would look at this algorithm in terms of how much potassium to give. So as I mentioned, if the potassium is near normal, they don't have to replace. Between 4 and 5, 20 milliequivalents, 3 and 4, 40. Below 3, don't give insulin and give 60 milliequivalents. So most of us would find giving potassium in a 200 milliliter rider is probably the best way to do it. Okay, so going through the patient then, the clinical assessment history. Are you taking insulin? Are you missing your doses? Look for infections. Are you compliant? This is first contact with patient, state of hydration, blood pressure, GCS. So it's very basic. Minimum measurements that's needed, obviously at glucose, blood gas, to look at pH and base deficit if one needs to replace with bicarb. Uni often is needed. Urine dipsticks to pick up the ketones. And importantly, if possible, measure the serum hydroxybutyrate where there is ketoacidosis. Calculating the anion gap is important. Measuring the serum osmo is important. And as I mentioned, basic ECG is often very useful as well. If one is suspecting infections, they do the usual. Don't forget to look in the ear, nose, and throat and the mouth for mucormycosis. This is it's not common, but it's one of the, but DKA is the most common setting where this infection tends to occur. And again, I mentioned look for complicating factors that may contribute to the DKA. So the myocardial infarct, the stroke. So as I mentioned, IVI fluids, 10 units of insulin if the potassium permits, single dose of long-acting insulin and bicarb at the quarter correction level if the pH is less than 7. If infection is suspected, antimicrobials, broad spectrum. If the patient is elderly, has full-blown a hyperosmolar state, then treat the patient as if they've had a DVT. So heparin at the full dose. This is to prevent strokes. To revise, crystalloids is started initially. As the blood pressure recovers and renal perfusion recovers, we may overlap with some dextrose water, particularly if the glucose drops below 13, and where we're behind in terms of free water deficit, one would then continue with dextrose water. Insulin, as I mentioned, long-acting as a stat dose, and IVI 10 units per hour until the resolution parameters are reached. Potassium has to be replaced by IV infusion, and bicarb can be repeated if the pH still remains below 7. Right, so what of monitoring? Vitals, GSC, urine output. So in other words, clinical monitoring, glucose hourly, potassium 1 to 4 hourly, pH as needed. So often this would be needed 3 times on admission, an hour or 2 after if bicarb is needed, and towards the end of the treatment progress, to make sure that the pH falls into the resolution criteria. Serum hydroxybutyrate, most labs do measure this, but remember there are point of care options for this as well. So this is the frequency of this measurement is much the same as a blood gas. So this is resolution. Right, so clinical, vitals are good, patient is awake, urine output is recovered, pH is now normal, base excess is normal, hydroxybutyrate is now normal below 3 millimoles, serum ketones is less than 0.6, osmolality is now normal, and glucose is normal. So these criteria would tell you that the astute clinician hasn't slipped, and the patient hasn't fallen. And at this stage, the patient can be transferred back to maintenance therapy. Okay, so just one slide on this concept of euglycemic ketoacidosis, and it's largely inherent on the use of SGLT2 inhibitors. So as you would know, the sodium glucose transporter 1 inhibitor does this. It inhibits glucose reabsorption in the kidney, in other words, lowers the renal threshold, and glucose at the level of up to 90 grams per day is excreted as glycosuria. So if patients are on this, and remember, we often use them in type 2 diabetics. They're also being used in type 1 and type 2 diabetics. We've got kidney injury, we've got cardiac abnormalities, because these medications are cardio and renal protective, so they're being used more and more frequently. They're even being used in non-diabetics. So the alert of this euglycemic ketoacidotic state is obviously symptoms of acidosis, low pH, low bicarb, ketones in the urine, and importantly, a raised serum hydroxybutyrate. So it's a high index of suspicion. And remember, in this setting, the glucose is totally incidental. Okay, so my last slide. I do some work in Alex, and whenever we have M&M meetings and we do case reviews and journal clubs, we often say we're trying to divert patients away from the opposition. And in this setting, I try to indicate, well, let's not slip on the way to treating DKA and HHS. So in summary, be aware of the 3 versions of DKA, HHS, and the hybrid variants of this emergency. Remember that euglycemia can prevail if the patient's on an SGLT2 inhibitor. The mortality staircase that I outlined is a very useful tool. It helps us integrate that pathophysiology and all those pathways that I mentioned, and it sort of ranks in a strategic way what we must and mustn't do in terms of treating the most important factors first, i.e. dehydration, acidosis, etc. I find that the formula are very useful. They guide clinicians to how much therapies we're going to need over the ensuing 24-hour period. So in other words, we can anticipate what's going to be needed. And it also guides us to more refined and more accurate fluid, insulin, electrolyte, bicarb replacement. Some of the refining strategies is that of a stat dose of long-acting depot insulin in casualty or on admission. Probably Ringer's is better. The herb is better than normal saline. The early use of dextrose water is also a refining aspect of the treatment. it replaces the free water quite nicely. We've got glucose as a substrate to resolve ketosis, and it tells us that we've restored intravascular fluid with crystalloid very effectively. And also it allows us, it prevents iatrogenic hypoglycemia, which does happen in this situation. And then last but not least, on a practical issue, if there were point-of-care machines available, this would be good. So in my former life as head of medicine at Charlotte, I did manage to get a point-of-care machine in the ward, in the endocrine ward that dealt with all the DKAs. And this certainly was very, very helpful. So, this would be my last slide, and I'm happy to take questions. Thank you.
Thank you very much, Professor Wing, for this this discussion that give us some information, more depth, but you said there's a lot that you can glean from the other documents, but I think this is quite important. Not so easy to come across as it has been put in a very concise and clear way. And it should be something that would be helpful to most of the clinicians who have logged in here. One thing that I wanted to check, because we've got a wide range of disciplines and practitioners. We also have sometimes nurses also, and also medical officers who work in the clinics, whether in the local clinics in the metropolitan areas or in the district services or in the rural areas, and GPs in the communities. Their approach to diabetes when they emergencies, like they've been seeing patients and suddenly a known patient comes there with an emergency. What the approach, what should they do? Sometimes they come with either hyperglycemia or hypoglycemia. Perhaps maybe just a stepwise approach to such cases.
So a diabetic that's collapsed, and the wisdom here is rather give glucose if you think it's hypoglycemia. So if patient just is in front of you and is comatose, and you haven't got time to do a blood sugar or a pinprick, which is rare, the standard teaching is rather, and this is mainly for the patient's family at home. So if there's any doubt, rather just put some glucose in the patient's mouth. So if the patient is a DK or hyperosmolar patient, so the glucose may go from 20, 30 to 35, 40. So it doesn't really matter, but you would have saved that patient from a hypoglycemic emergency. If we know that the glucose is high and the patient is comatose or near comatose with a low GSC, then obviously start resuscitation. I don't mean, the resuscitation we're talking about in the ICU setting, but put up a drip of Rigazan and or normal saline. That is the most important, because remember, if you tackle the dehydration, the sugar drops, the perfusion improves, and many aspects of the acidosis also improves. So that buys you time then to do the glucose and to look for other things like infection or whatever. But that slide that showed the initial basic bloods obviously is important. So in the rural area, if there's no lab available, one can still use a pinprick, a capillary glucose. One can still use the ketodiastics in the urine. If the patient is overtly acidotic, one could correct the bicarb safely, as long as you don't do it, as long as this is not corrected fully. So to me, So reverse the shock. Use a ketodiastics. And if the patient is overtly acidotic and you haven't got access to a blood gas machine, it may be useful giving a very small dose of bicarb. As home remedy, or yeah, sorry.
Okay, no, go ahead.
No, I finished, so you can ask the next question.
Okay. Yeah, I see Prof. Makunyane's hand is up. Prof. Makunyane. Go ahead, Prof. Makunyane, and unmute yourself.
Okay. Thank you very much, Professor Wing, for an interesting talk on diabetes and diabetic emergencies. I actually just talking about the slips, that you mentioned. I was faced with a patient actually a few days ago coming for an ophthalmic examination anyway because he's diabetic, young, and he has, he's insulin dependent, and just I think he used to work from 8 to 4 at work, and now his schedule was changed to odd hours, such as the early hours of the morning to 9 o'clock or something. So there was just this change in his schedule, and therefore, the schedule of his taking his insulin and eating habits completely changed. The next thing is he was admitted in hospital with in DKA. So we just had this conversation about this and wondered how much changing the schedule of taking your insulin and your eating habits can precipitate DKA. Thank you.
Yeah, right. So compliance is the major factor in DKA. And unless there's overt stress, in other words, organic stress, a definite infection, COVID or something like that. If it's purely an insulin story, then usually it's not missing 1 or 2 doses, but it's usually 5 to 7 days with no insulin. So I would imagine this young patient's schedule was so hectic that he or she probably missed 3, 4, 5 days of insulin. So, I mean, to address it is then to try and adjust his insulin regimen. So the trick here is that, and it may be difficult in the public sector because of the insulin preparations we have, but certainly in the private sector, what you can do, because the new insulin preparation and regimens are much more modern. The philosophy is here is design the insulin regimen around the patient's lifestyle. So not the cart before the horse. The horse is the patient and the cart is the insulin. So the insulin regimen should be synergistic with how the patient lives and eats. In the public sector, it's a little more different with the older insulins we have. Here, the patient has to follow the insulin regimen, the insulin pharmacodynamics, because the old insulins don't lend to flexibility. I don't know if I answered your question.
Yes, you did. You actually did. Even though he was insisting that he does make sure that he gets his doses every 24 hours. He might be slipping up with the meals, perhaps that he might be skipping some meals, and I take it that he would also change his insulin dose, So, so he was kind of puzzled himself that he's never had a DKA, and this is the first time, and it happens to be a patient in private sector.
Okay.
Quite interesting.
Okay.
Very interesting. There's a question, you might even ask, maybe you didn't discuss this one about gestational diabetes. They wanted you to discuss this. I think Prof. Adam is here. I don't know if you are able to comment on that, Prof. Adam, unless Prof. Jeff Wing you want to comment on this. It's a very broad question. So I don't know exactly what they want you to cover, but just maybe 1 or 2 words on gestational diabetes.
Okay, so I can, Prof. Adam can add in later on. So from a physician point of view, this is diabetes related to the pregnancy state. So pre-pregnancy, no diabetes. During pregnancy, diabetes manifests. Post-delivery, patients is back to normal, so no longer diabetic. However, this patient is at risk for future diabetes. Regard pregnancy as a stress test in terms of beta cell reserve and insulin requirements. And the patient, even if the patient is normal post-delivery, the patient has a higher chance of developing diabetes in later life, at the rate of maybe 10% per year. But gestational diabetes can present with not so much with DKA, but certainly with the hyperosmolar state as an acute emergency.
Okay. Thanks for that. I know, Prof. Adam, do you want to comment or you'll come later?
Ray, it's 7 o'clock.
Yeah,
if
okay.
you want to listen to, to the other lecture.
I can see the numbers are dropping now quickly.
Yeah.
I want to listen to the president. But maybe quickly, let's deal with this one. How
Okay.
much long-acting insulin do you give?
So I normally give 24 units because most you're talking about that stat dose of long-acting insulin. Yeah, about 24 units is usually sufficient. Remember, most of us need a unit an hour of long-acting insulin.
Yeah, and then this last, I think we'll take this last one.
Okay.
Then you can listen to the president. If you're epileptic and diabetic, what is the easiest way to get their glucose levels down before they have seizures because of high glucose?
Okay, so epileptic, obviously hypoglycemia is a no-no because it would precipitate the epileptic seizures. So important there is to keep the glucose above 4 so we don't induce neuroglycopenia. So I would target the glucose between 4 and 8, even 4 and 10 if necessary. And then if the patient is type 2, one could use agents that are non-hypoglycemic inducing, GLPs, DPP4s, SGLT2 inhibitors that don't cause hypoglycemia. If the patient is insulin requiring, then using short and long-acting insulin analogs, which induce less hypoglycemia, would be advisable. But again, important here is to target 4 as the minimum and not push that glucose lower.
Okay, sure. I see colleagues want to ask more questions. Julius is not in Parliament tonight, so the president will not have any disturbances, so he might have a good time to talk and finish quickly. So we better get ready and go and listen to him.
Okay,
so Dr. Mashipa, yeah, and Prof. Wing also wants to go and listen to the state president. Dr. Mashipa,
yes.
Dr. Mashipa?
A quick one here. How
Sure.
common are these crises in your LADA and your multi-type diabetes?
Usually not too common because they still have some degree of beta cell function. So this would usually be in the type 1 patient, obviously, and the HHS would usually be in type 2s that are really non-compliant, or type 2s that have had a precipitating event, an infection, or a type 2 that's had a complication, but usually not in young modies.
Okay, are you okay, Dr. Mashir? I know you're one of our best participants asking questions. But we'll reserve you for the next time. But you must also present, Dr. Mashir. But
Yes.
lots of, yeah. Colleagues, we have to stop here. I
Yeah.
saw Dr. Nivondo send us Abata. He has dropped it, and he's also one of those who does presentations, and with his orthopedic surgeon. We'll slot him in later in the year. So, colleagues, I just want to thank you, Professor Jeff Wing, for this wonderful presentation that you've given us this evening on diabetes emergencies. Just to check, normally when we've been talking that a PDF presentation, would it be okay if
I'm
we've got
happy.
one we can share it with the colleagues who are here? Because there's a lot of information that they can look at.
Okay.
Yeah.
But I'm happy to share the slides as well. It's not a problem.
Or you can share the slides. Okay, just share them
Yeah.
with us, and then we'll then share with the colleagues here.
Yeah.
Okay. But just thank you very much for taking your time and sharing this information with us. And we hope to have you back sometime again later during the course of the year. Diabetes is
No problem.
a subject, that we all have to know much about. And to thank all the other risk committee members who joined us this evening. Thank you very much for being here, Professor Mokuyane, Professor Mangren, so Professor Adam much earlier for being part of this discussion this evening, being with us. And to thank all the colleagues, our regulars and new ones who are coming in. And still, we've got large numbers, more than 300 who participated and logged in this evening, despite the fact that there's the state of the nation at us. Thank you very much, and do not take that for granted. And we also want to thank Gamo, who's been our pillar strength in the background, and joined now will be Anzamadi, who will be with us also, helping us in terms of logistics and making sure that we have a good presentations, and we cover a lot of ground. And also to thank the clinic's executive for allowing us to have this time to always be part of these webinars, and for sponsoring them. And we thank you, and we pray that you will have a good time listening to the president. And unfortunately, we couldn't make it to the finals, Bafana, but let's hope that we'll get to the cup for the losers final.
They slipped. They slipped.
Yeah, they slipped. They were not so astute, but they tried their best. And they missed the cup. So have a good night, colleagues. See you later.
Okay.
See you again next week.
Bye. Bye.
Thanks, Jeff.